Hi there, my name is Dr. Ian Katz. I'm a dermatopathologist, and I thought I'd use a case to illustrate the difficulty in reporting and describing margins with melanocytic lesions, particularly melanomas. So just to remind you what happens in the laboratory, we have an ellipse of skin with a pigmented lesion in the middle, and we bread loaf the entire specimen. We take 1, 2, 3, 4 samples, and that's not quite correct here because and then we take a thin slice off the surface of each sample and pop that on a slide, stand it up and have a look under the microscope. So in other words, the bottom line is that we examine very little of the specimen, and we examine even less of the margins. And negative margins therefore mean very little, particularly in shaves or biopsies. And that says the same thing. So this is a case that I'd like to illustrate that came in about a month or so ago. This is the original shave biopsy, and this is the sun-damaged dermis here, and this is a confluent proliferation of atypical melanocytes at the dermo-epidermal junction consistent with melanoma in situ. There's not a lot of pagetoid spread here, which you'd see as atypical melanocytes coming up in the epidermis, but you don't really need that to make a diagnosis of melanoma in situ. Another area here of confluent nests of atypical melanocytes. And although it's not that clear here, the margins were a little bit uncertain in this shave, but it certainly couldn't say that the margin which is here was clear. So then you look at the wider excision, and you can see there's a large dermal scar here, and you get a proliferation of melanocytes at the dermo-epidermal junction with a little bit of pagetoid spread here. The problem with this is, of course, is that you get pseudomelanoma above scars, but I do think there was sufficient atypia in light of the previous biopsy to call this melanoma in situ. However, the problem becomes what's happening around the specimen. You can see here this is a composite picture of 3 or 4 different pictures, and this is the resection margin down here, and you can see that there, even at this magnification, quite a few single large melanocytes at the dermo-epidermal junction, more at this end than close to the margin, although there are a couple down here as well. And you can see this in higher power of the part on the right, and these are quite atypical melanocytes at the dermo-epidermal junction. The problem really becomes are these part of the melanoma? Is this a background atypical junctional lentiginous proliferation? And really, how does one report this in terms of the margins? This is a composite picture of the other resection margin on the other side. This is the margin here. A bit of a solar keratosis here, and again you get these atypical lentiginous melanocytes petering out near the margin. A bit of a higher power here of these atypical melanocytes. There's quite an atypical looking junctional melanocyte. You of course do get similar cells in sunburned skin, which can also make things more confusing. The other issue really is, and this is not particularly with melanocytic lesions, is how does one measure the margin, and what is the measurement? So you can see these 2 or 3 different ways of measuring margin. You can, for example, if this was the end of the melanoma here, that could be your measurement to the margin, because that's the margin of the epidermis. This could be the measurement of the margin, because this is a margin of the dermis. Or does one try and estimate the curved margin of the epidermis, which is probably the real clinical resection margin that hasn't been shrunk? So there's one, and this is the same with basal cell carcinomas or pigmented lesions. What is the right measurement to report? There really is no correct answer to this. So the take-home messages of this case are that it's very difficult to determine the exact peripheral extent of melanomas. And in fact, that's one of the diagnostic criteria for melanoma. One of the criteria is that the edges of the lesion peter out. And in these cases, you can often have a background atypical lentiginous proliferation, as in this case, and it's really difficult to determine which is the melanoma and which is just a background lentiginous proliferation. The other issue, which I didn't mention, is that with fixation, sometimes melanocytes can look a bit prominent and atypical, and you do have to take this into account when you're looking at the slide. The summary of that is that one can imagine how difficult it would be to do Mohs surgery on such a lesion where you don't even know which are the malignant melanocytes and which are just the atypical indigenous proliferation and which are the normal melanocytes. It would be very difficult to measure, to determine which melanocytes are at a margin. As I've said, how does one measure margins anyway? The other issue, obviously, with melanomas is keep in mind that the margins recommended are clinical rather than pathological margins. And the final point is that we only examine a very small proportion of the margins anyway. We're probably examining less than 1% of the margins. So for all these reasons, one can't be too dogmatic about wanting 5 millimeters rather than 4 millimeters or 3 millimeters or whatever on these pigmented lesions. One's got to take the clinical picture into account. Just wanted to finally remind you that the NH and MRC guidelines for melanoma management recommend clinical margins. So, for example, if you take 5 millimeter clinical margins for a melanoma in situ, but you only get 2.5 millimeter margins on pathology, this may be okay as long as the sampling is adequate, the sampling of the margins. So you could potentially ask for deeper levels or more sections of the tumor just to be sure that you've got good sampling, or you could even discuss it with the patient and see what the patient wants to do. So don't necessarily take wider excision if the pathological margins are narrower than the clinical margins.